welcome to another session in the Formfast Educational Webinar Series. I'm Aaron Vaughn, Director of Marketing here at Formfast. Thanks for joining us. In this installment, we heard from Sean Curtis, Director of Product Management here at Formfast. He discussed the need for better utilization of data to drive process improvement and therefore produce better outcomes. And in case you missed that, the recording of that webinar is available in our webcast section of our website at formfast.com/webcasts. And the title of that session was Better Processes, Better Outcomes. This is looking at the need to improve healthcare organizations from a more global view in a presentation entitled The High Performance Hospital. But before we proceed, just a few housekeeping items to review. First, note that the audio from this event will be broadcast through your computer speakers. If you're having trouble hearing that, please contact me via the chat window. We'll preview to join the teleconference, and once you're approved to join, then you should be able to connect to that. Once connected, make sure that your computer speakers are muted, however, otherwise you might hear an echo. Please, any questions or comments at any time, the presentation in the Q&A section or the chat window on the right side of your screen. We will be giving those to the end of the session, but feel free to send them whenever you think of a question. And for those of you who are joining us for the first time and might be unfamiliar with Formfast, we want to do a quick run-through of who Formfast is. We provide automation solutions for healthcare, including eForms, or electronic forms management, workflow automation solutions, business intelligence tools and process improvement tools, electronic document storage, and output management solutions. We've got over 900 hospital clients internationally, as being the preferred or formal partner with industry leaders such as Meditech and McKesson. We're number one in eForms management in healthcare, and we have 20 years of industry expertise. At this point, I'd like to introduce our speaker for today, Scott Fuller. Scott is formerly Director of Information Services and Director of Business Intelligence at Doctors Hospital at Renaissance. Doctors Hospital is one of the most respected healthcare providers in the country, and considered to be one of the most profitable in the United States. During Scott's tenure there, the hospital grew from 83 to 508 beds, and they implemented a number of health IT tools, including workflow automation, to manage tasks. Scott is also a noted author, or corporate president, and a thought leader in business intelligence in the healthcare community. Currently, Scott is working on his 14th book entitled Creating the High Performance Hospital. We're also very proud of him serving as our Director of Solution Architecture. So Scott, at this point, I'd like to turn it over to you.
Aaron. One by you get screen up. Good morning. We're speaking about Performance Hospital today, and it's part of the educational series here at Formfast. So this is meant to be more kind of a tutorial and something to get you thinking about process improvement at your facility. Not so much a software demo. I will be showing some of the screens, but it's just to help sort of new to electronic forms and workflow automation kind of possible. And again, it's just whet your appetite. And my goal today is to get you thinking about what's necessary at your facility to do process improvement and what are some of the good areas to start in, and maybe even start some of the conversations that need to take place at an organization. Just the hospital in the country right now is at a point where they've been doing things for a period of time, and it's a lot of things that have come into play and other things as well that it's time to sort of start rethinking about what we're doing. And I kind of relay that back to, sort of a race car drivers do to a car. You just don't buy a car and take it out to the racetrack and win races. If you try to enter a race with a stock just a plain old car, you're going to come in last place. I think one of the things that hospitals need to do is sort of reinvent themselves and look at themselves, at how can we get these individual areas and become a higher performing hospital, and run the same way they do it in racing. Buy a car, they look at each individual system, each individual function, look for inefficiencies, see what's wrong with it, how can we make it better. Then upon reassembling everything into a whole, a much higher performance machine. And the same mentality to look at a hospital with, taking individual areas apart and looking at those pieces. Now is the time, probably more than ever. I've been a believer in this for quite some time, but now even with the change to Medicare and revenue, there's much less coming in, and hospitals are being forced more than ever to be more than what they have. Now that you have an increasing amount of competition for the same healthcare dollar, unless you're in a critical access area, you probably have a neighboring hospital that's competing for the same healthcare dollar. And because there's less revenue coming in, that competition's getting a little more fierce. And it's not just other hospitals, but it's other technologies that used to be found in hospitals that are now being found in clinics and other outpatient facilities. There's more people competing for that patient's attention than what you had in the past. And here is huge. I've heard this, I don't know how many times, from different hospitals. They're doing twice the amount of work with half the staff. I don't think I've been in a hospital in the last couple of years where that wasn't true. Everyone is usually hospitals are suffering with a great deal of workload. It can be because not just increased volume of patients or a high volume of patients sitting in the hospital, but it can just be other initiatives that are taking place at the hospital. Implementing an EMR, I went through that at my former facility. We went through it, and we got stage 6, and I'm well aware of all the pains at each level and the increased workload on not the IT staff, but the entire hospital. It's a process for an entire hospital to go through to put in an EMR. Because of that, everyone is stressed, and they're having to do more work than they have in the past. And really, I think it's kind of time for a culture change. A lot of the ways are doing things at a hospital are the same way we've done them for years, and sometimes we need to just step back and look why are we doing it that way. I can think of something from my old facility when I was doing some due diligence when we were preparing the surgical area for placement into our medical record. There was a green form, and there was a little bit of concern about a green form because once you put something in, once it's electronic, you're usually dealing with black and white, and a green form with black print is a little unusual, and plus some imaging systems won't handle that. So the question came up, well, why is this form green? Well, if you talk to HIM, they would tell you that the physicians in the OR were the ones that needed this form to be green. It was very, very important that it was green to the physicians. Go down the hall, talk to some of the physicians and hospitalists. I don't know what color the form was, but it was their impression that it was something that came from compliance or resource management as to why this form had to be green. And talking with both those departments, they were under the impression that the OR doctors were the ones that had to have the form green. Getting to the bottom of it and making a story short, it turns out that at one point, in ordering this form from a local print shop, the shop messed up and printed our form on green paper. And they had quite a a bit of it because at the time we were ordering quite a few forms. And we started using it. They basically gave us the form half price because it was their mess up. And then the next time we went to order it, the person that ordered it basically thought it was supposed to be green. Hence, from that point on, the form was always green, and it never had to be. There's a lot of things like that in a hospital. The way we do things, sometimes we do it because we think this is, it's been dictated by some other department, and it's time that we sort of step back and take a look at that. And kind of along in those lines, when we were implementing EMR, what we were doing for the clinical area of the hospital. Implementing EMR is a tremendous thing. It really does change the way you provide service to patients. Their records electronic is a huge advantage. There's a lot of safety issues are very, very, very positive with that, as well as compliance. But really, when you're all said and done, you're looking at it, you've only addressed about a third of the hospital, the clinical part. You really haven't done much for revenue cycle, and you really done much for support services. And so two-thirds of the hospital that are basically doing things the way they've always done it, and you've sort of turbocharged the clinical part. In our CIR facility, we were sitting down and talking about it, and we just decided, you know what, we are going to look at things from the leading doc to the bedside, not just what we're going to do in the clinical areas, and things that we were going to do with CPOE and implementing the EMR and all the benefits associated with that. So just all the back office and revenue cycle type functions. What are we doing there that's wasteful, that could be better, that can bring costs down, that can cause money to come in quicker, increase our cash flow? How we can repurpose staff that are bogged down just doing paper-related things. That's what we were going to, come in and attack. Excuses, and again, these were even excuses from my former facility when we would sit down with people and try to talk about in areas. And, I think the common one is this is the way we've always done it. Well, yeah, and like I mentioned with that green form, that's not always a valid excuse. Until you get to the core of the reason why you've always done it that way, those things may have changed. There may be other systems in the hospital that have sort of equated the purpose and the reason why you're doing something that way. So that's definitely something that's, a very good excuse and something, we kind of have to explore further. The next one, our hospital is just different than others. And this is certainly true. No hospital is exactly like another one. I've seen, very large, sophisticated, marquee named hospitals, and they operate, a certain way, and they have, their own value system. Other hospitals are very small. There was one I was at where the was literally also the receiving clerk and the purchaser in materials management. It's just, depending on the size of the hospital, the market you're in, other initiatives that you have in play corporate-wise, really are different than others. And you don't have to that up and, adopt some sort of cookie-cutter process enhancing your workflows and your systems in your hospital. What I speak about is just looking at the way you do things, the way that's important for your organization to do it, and still try to see if there's a better way to go about it. Just defeat yourself and say, well, automation or doing things in an efficient way, that just probably won't work for us. We're just small, or we have these other initiatives in place. It's really, this mentality can be adopted by anyone, and striving to be a high-performance hospital is a goal, whether you're large or small. And I can even argue that if you're small, it's probably more important because you have less resources to begin with. And so every little man hour that you can save here and there has such a huge impact. And for a relatively small hospital when I started, and I definitely know what it's like for people to wear multiple hats. It's too hard to change the way we do things. Well, that's a truth. I don't know if it's too hard. There is a challenge. Most hospitals are sort of in that challenge right now. In the clinical third of the hospital, with developing their EMR. You are certainly changing the way doctors and nurses do their work. It's not easy. I've been there. Physicians that absolutely have reached to use a mouse. Physicians that have walked up after we're up and running and stage 6 certified, walk up to medical records and demand entire printout of the entire chart because they want to take it with them. It's a process change, but that change and the pain of change is necessary. And I think you're experiencing some of that in your hospital right now, implementing your EMR. Even though it's scary to think about changing more, it's actually a good time to do it because, frankly, you already have users of the hospital. Users, I mean employees, users of the systems in the hospitals. You already have them somewhat on their heels because of change, and it's kind of better to implement reaching changes that have benefits to everybody. People can understand and go through some discomfort in learning something new if they can see some benefit in it. And if they're doing that just to maybe help out another department because they don't, maybe electronic medical record really doesn't mean much for their department and their things. Other things, other workflows, other changes in their area, it motivates people to make a change. And when you do it enterprise-wide, when you look at this organization from the loading dock to the bedside, that's where you're going to make the most significant changes in your hospital. And this is where you're going to see the biggest payoff in being, the benefits of becoming more efficient. It's not just going to be something sporadic in different areas. It's going to be across the board. The comment here is it's all soft costs. And for those not accounted, it's soft costs to your controller or your CFO is man hours. It's something that isn't necessarily a hard dollar. You're not necessarily saving the hospital from spending that dollar. An example would be if you repurpose an employee, if you change a workflow, this employee's job changes, you're necessarily terminating that employee. Certainly it can happen. I don't think I've ever seen it happen. Usually that employee gets repurposed somewhere else in the hospital. The aggregate of those soft costs really do have a hard cost impact because long term you yourself being able to do more with less people. And hence you are actually saving payroll. An example from my facility, we had a Kronos system, and Kronos is a very good system, absolutely nothing wrong with it. The issue we had with Kronos was that in the software there was no functionality for a director to either hire, fire, or transfer an employee. In talking to Kronos at the time about what's from you handle this, they had suggested, well, you can do it via email, or if you have that triplicate form that you used for years, you can do that. Well, we're away from that kind of paperwork. Triplicate forms are just expensive to there's issues when you are shuffling paper between departments. Things get lost. It's hard to know something's at, and we'll talk a little bit more about that in a little bit. But what we did was that we made that form electronic. When you, as a director, you had access to it, you could pull up the form, you put in somebody's Kronos number, and the form would automatically populate from a database. So all that information on the form would be filled in correctly. You didn't necessarily have to know the person's full HR name. I had an employee, her name was Maggie Pena. HR knew her as Margarita Pena. Work always had to be done with the name Margarita on there just for the sake of being correct. And in the paper world, the HR department had one employee who would take all the incoming envelopes, open up, and literally just go through every form that was being submitted, just correcting mistakes or filling in blanks. Sometimes directors would be lazy and not employee number, or they didn't maybe have an idea of an employee's actual job code or title, so they would just leave it blank. And this person would just sit there all day correcting the forms, then submit them for processing. So right there, one, there's a delay in the process. They're being held up necessarily in some cases. And two, you have an employee that's doing nothing more than just validating other people's work before the form gets processed. It was electronic, and we were filling out the form by putting in the Kronos ID, and everything was being filled out. When that form routed electronically to the HR department, there's absolutely no need for someone to correct it, because every populating on the form automatically came from the source of truth, which in this case was Kronos. Depending on the form, the source of truth might be your HIS system. It could be a variety of other things. But in an HR form, it's going to be your HRIS system. So that was basically repurposed. She actually went on to become a recruiter. We were needing more recruiters, and she had worked in the HR department enough. She was familiar with everything, and she was moved into that recruiter position. It was a position that the HR director wasn't able to necessarily justify a new full-time FTE, but much easier adjusting an existing FTE to a new title, as far as, fighting the battles, as far as getting new staff. So soft costs do have a hard cost edge to them, and I know that was a long story to get there, but you do have, there's an aggregate value to soft costs, as well as there's a lot of things you can do that are not soft costs, and we'll talk about some of those. There's a lot of workflows that actually have a true dollar in the door effect that actually can happen immediately. And those are some of the best areas to look at initially as well, because if you're going poking around, making things a little uncomfortable, the suggestion is try to find a couple areas that are going to be big home runs, big winners. In a hospital where you can make a big impact, and that wins more people over, and you have more champions for change doing so. So talking about all this, and workflow are these building blocks. These are the things that we're going to we're going to take a stock from a dealership and break it apart and make a race car. We're going to bust everything down into workflows. Workflow is something that can transcend a department. It's not necessarily just a HR workflow when you have other people, directors, and maybe benefits and payroll and accounting all working off of a particular process. So you really look at things not so much by departments, not so much by what individual departments do, but actually in a workflow. Look at something from beginning to end. And when you start looking at things this way, it's kind of interesting. I've had it myself, and I've talked to other customers that have gone through the same thing, and it's really an interesting way to start looking at your facility, because everyone kind of has a tendency to look, in a hospital for a while, there's sort of these little turf lines, and you have a tendency to look at other departments' work as the other department. I'm familiar with what my department does with this, and then hand it off to that department, and I really don't know what they do. I know they do something with it. I know things are important about it, but I really don't understand it. And none of that. So when you look at a process or a workflow, look at it, beginning to end, where it starts in one area all the way through to its completion. So you see how many departments are touched by that. For me, when I did this, one of the most eye-opening conversations I had, and I can tell you this was eye-opening than talking to the COO or quite a few other directors, it was talking to Frank. Frank was our term mail guy. He was the guy that had the cart with the inter-office envelopes that went all the hospital, and 3-4 times a day he would load his cart into the back of a little pickup and he arrived to other areas of our campus as we grew and became bigger, and delivered and picked up packages. Talking to him, it was very interesting. Frank really knew everything to know about workflows in the hospital. He really didn't know what they were. He was looking at them abstractly. He's getting envelopes that are filled with information. Looking inside the envelopes, he knew that he picked this up at this one area, and he would go over to HR, have them sign it, and then he had to go get accounting to sign it, and then he had to rush it over to the CFO for approval, and then he had to rush it back and forth. And he knew there was some just natural inefficiencies like that. He knew without even looking inside the envelope, there must be a better way to do this, because there was a lot of people stressed out over what's inside that envelope. Sometimes just the process itself was inefficient. And just even from an abstract view, just looking at it from an envelope, you can tell that the side is not being shuffled sufficient form necessary. And I think having that conversation with Frank was it was my awakening as to really bad things were on the revenue cycle side and our support services side. I mentioned the facility I came from, we were 83 beds when I started, and in 6 years we grew to 508. And that wasn't through acquisition, that was just through growth. And so we had a lot of processes that were great for us when we were smaller, 83 beds. You know, a lot of times we're still using those processes when we were larger and really grew them. And that was just a great place to start, talking with Frank and talking about, how workflow pieces were not flowing so well in that paper world. Screen right now is an example of a more sophisticated workflow. This is actually a workflow from my former facility and how we handled rack audits. Rack audits for us were a little bit of a challenge. We were the last hospital to get its charter under the current revision of the Stark Law. We were physician-owned, which means we had 400-plus doctors, all of whom thought they were CEO. That added some additional challenges to us when we were trying to do rack audits and trying to get things through an audit process that included those positions in 45 days. It was definitely a challenge. To this, and step into any process review, would you diagram it? You don't have to draw pretty little boxes and code them, but if you just, on a piece of paper or a napkin in the cafeteria with a pen, just documenting a process, how it flows. Again, this is a perhaps more sophisticated one, but you start looking at a process that exists currently and documenting it, and then once you document it, it's easier to talk about and look at it. One thing in particular is if you have a process, a form that's traveling through your hospital and it's paper-based, because it is paper, certain limitations. It can only be in one place at a time unless it's photocopied. Photocopy it, now you've got some issues about you're not controlling those copies and what happens to the original, what happens to the copies. You have types of issues. We that from electronic, or the contents of that envelope electronic, all the attachments, everything, all electronic. Now something can be in multiple places at one time. Different can be looking at it, different people can be working on it, and change the way it flows. And that kind of changes the way you talk about it. Again, step one to that is just getting the process documented, getting things looked as to how are we doing it today, and then breaking that process down to how can we make each individual step a little more efficient. Are we doing things this way just because it's paper? What if we made this electronic? How much can someone get through the system? What advantages is it to getting through the system? Getting through the system faster, if you're talking about a claim rejection, that has hard dollar ramification to it. If you're about getting something through the system faster that is our form, you're talking about happier employees and probably reducing in your HR department. if you're talking about getting a accountable invoice paid, approved and paid quicker, you're probably, again, talking about, saving late fees and also decreasing workload in the accounting department. All these areas are good to look at. We'll talk about that in a little bit, too. We're going to go through a couple example of revenue cycle workflows. And revenue cycle is kind of a little bit of discussion as to where the revenue cycle starts. In my opinion, it starts in registration. There are things that representative does, the information they collect will have huge ramifications throughout the entire revenue cycle, a way to payment. If they fail to do their job correctly, it makes things much more difficult for the billing department and your business office to do their job. When collecting information correctly and it's being communicated very quickly and simultaneously to the other departments in the revenue cycle, the whole machine works faster. When the machine works faster, you're getting your bills out quicker and you're getting your days down. The facility I came from, we worked ourselves down to a full bill that was 4 days after discharge, which is impressive. And to prevent a lot of late fees or things like that to occur on a particular patient visit, that really represents a lot of work, more than just what obviously coding is doing. Coding has to be working very, very efficiently in order to get the bill out the door after discharge. But all the departments have to be working very efficiently in order to not have a bunch of late fees or be missing charges on that bill. Having the whole revenue cycle kind of right rails has a serious hard dollar effect on your hospital and your collections. The minute we went to that 4-day final bill, our AR days dropped below 50 days. It was direct correlation, and I've talked to other hospitals that had similar issues. When you can get the bill out faster, you make some other adjustments along the way, your AR days also drop. And getting your AR days under 50, that's a pretty number. You can certainly do better than that, but I've also worked a lot of hospitals where AR days are 100 days, and they're just leaving too much money out for too long. And the longer that dollar is out there, the less you're going to have of collecting it. And, that kind of sounds like a business office problem or issue, but again, we're trying to look at things not in the viewpoint of turf. It's the business office's problem to collect that money for the hospital. It's an end result of a workflow, or it is a workflow in itself, actual workflows actually in the collection process. And it ties in everybody in the revenue cycle, and so any enhancements you can make along the way contribute to better collections and get more money in the hospital. One of these workflows I want to talk about, and this one's going to be a little more in depth, just for those people that are on here that might be a little new to an electronic form looks like and how an automated workflow can work within an environment. I just kind of wanted to talk about a rather simple one. It's a very simple, when we're talking about drawing it out, kind of 2 steps, and it's a coding query. A coder has a question about their patient. They would query to a physician. In the electronic world, this is done electronically. The physician signs it electronically. When it's signed and answered, a copy of it goes right into the EMR where it belongs. That way the EMR is always collection point of all things related to that patient. Also, kind of courtesy, a message or an email or a copy of it, a variety of different things can go back to the coder directly. So the coder knows the physician has responded. So there's no delay time in waiting for over a day later that the physician has already answered the query. And talking about drawing this out, you can see this is a very simple, kind of like a 1-2 step process. The same process from screens. What you're right now is a McKesson product called Horizon Patient Folder. You don't have to be a McKesson shop to have this. It's a rather popular but this is just an example of how something might be integrated. So I'm using a McKesson product for this, and what we're doing is we're looking at a patient record, and we're looking at it from a coder viewpoint. It's something that's their job to be coding this, and they have some question about this in general. So directly from the screen, actually launch the product to where they're not having to go out and click another icon and look up this patient. What happens is when they select it, it comes up a form. And the information has all been populated, what I call the source of truth. In this case, it's the HIS system. It should be your source of truth when it comes to all things patient-related. So we're getting all that little bits of information out of that patient's populate this form. So one, the coder doesn't have to do this, taking up time. Two, this is human typing, so less chances of something being typed wrong. You may get everything right, but they mistyped the patient's name, and for some reason that name doesn't ring well with the physician. The physician has to go look up the medical record number to actually find out who you're talking about. All things that can cause aggravation and delay in the cycle. So really the first thing that's coming up is all this information is populated, even the coder's name, because we know who's logged into the system. All has been populated. So the thing the coder's typing is just whatever the query is. What is the question? And so it makes that whole process so much easier than it was prior. Now, from the physician's standpoint, do something like this can be through a portal. Again, we're looking at a McKesson product. This is just one of many portals that are out there, but this is the one screenshot for. This is WebStation for Physicians. It has kind of several different names. McKesson likes to call it different things, but it's part of the Horizon suite of products. But if you notice, this coding query is showing up here under deficiencies. It's circled in red. And so we're actually giving this physician in space that they're already familiar with. You're not forcing the physician to go check some crazy inbox somewhere that they're not used to using. Because frankly, if you tried to do that, if you give a physician somewhere else to look for things other than the portal or his existing email, it's going to be a battle. And it will be very similar for actually other employees as well. Things need to be integrated into an existing mail system or other portal system to make things easier. So from a physician standpoint, at this web station, they see coding query. They're already kind of triggered to just clearing their deficiencies. It's just part of their routine whenever they log in. So they hit coding queries, and they immediately are brought to the forms where they can see, oh, here's their 2 coding queries. And as they open up the form, they see everything, out their responses to it, and they're signing it electronically. And like with a lot of systems, there's other parts you can do on the electronic signature. You can certainly require a PIN number, other things of that nature. But just an example of what an electronic signature looks like. So after it's been signed and completed, that document is now back in Horizon Patient Folder, or back in the EMR. Everyone see it immediately. The code probably also given an email message that this has been completed, and that little workflow loop is now complete. This because of the fact it made it electronic. It's much better than faxing something and trying to follow up. You can tell how long a physician has had something on their deficiency list, a lot of their advantages to that, and we'll talk a little more about that in a minute. Another example, this is kind of an accounts receivable workflow I was working with just of last year. And this is just surrounding government payments. And it's a process that started there and is quickly expanding to other areas in the business office. And a drawing just to kind of explain the process. And again, this is another very simple process. Not all workflow processes have to be multi-stepped. Some of the very simple ones are the ones that, just because of the sheer volume, are some of the best ones to start looking at. The process of claim rejection and denial. One is a specialist would receive a whole series of claim rejections, several hundred a day. You have to look through it and find out why the claim is being rejected, and then make a decision as to who in the hospital send this to get the necessary information, then be returned to them so they can contest the rejection and then hence get the money. This is a everyday activity in almost every business office hospital in the country. Different hospitals, different teams, but the process is the same. Again, we're only talking about just one facet of that in this example, and that is government payments. We're not talking about private insurance, other, this is just government payments in this particular facility. Just another screenshot of the form that they designed. Kind of going back to that one objection that we sometimes hear of, well, our hospital's just different. To adopt a form sort of dictated to you, you can control what your form looks like. The aspect of the form can be unique to your facility, where it makes sense for you. This form has a lot of drop lists, so you can make it easier, or you can control what gets filled in certain areas. Certainly can keep it as very personal to your facility and work for you. And that's actually, in my opinion, very advantageous, because you're not trying to adopt some process that works well for another facility, trying to make it work for yours. Just looking at your facility and adapting a set of tools to the process that was just exactly your facility needs, to turbocharge that little area. That's what's important. And this little claim rejection form, this is something that's particular to that particular hospital. This was only initially used for government payments. It's sort of a forerunner for spreading out through all denials and rejections. A form that would get filled out. Talking about just the ROI around this, and by I mean return on investment. When we were looking at what kind of dollar amount effect you're going to have on this process, we looked at a couple things. On the top part here, under where it calls payroll savings, this is kind of what you would refer to as soft costs. You had a government payments supervisor that was higher paid than the four specialist that she's in charge of. But, every single hour they were working, there's $56 represented there. Of course, probably more than that by the time you figure in benefits or whatnot, but we're conservative. So, every hour that they're working, that's $60 the hospital's paying. If you just save a half an hour, and this particular workflow actually was proven to save much more than that, but if you're just to save a half an hour of that, look at the yearly savings on that. That's over $68,000. So if you save each of these people a half an hour's worth of time, you are making a huge impact yearly. To the point where you could probably have, 2 additional employees for that same amount of savings. This is kind of where soft dollars start and do have an aggregate effect on something. It's something where you're immediately going to say, okay, we've got our budget here, but it's going to, in an aggregate, build up to the point where you are going to be able to stretch your payroll dollar to cover more FTEs, and that makes a big difference. The bottom part of this ROI, this is hard dollars. And again, we took a very, very conservative view of this. The number of billing sections received each, they estimated it was probably closer to 150. I cut that number in half, and we used 75. There were people involved. Really, the supervisor was a working supervisor, but again, just conservative, I just went with 4. And the next part was the average governmental claim size. Your average governmental claim is really more like 1,500 to 2,000, but again, very, very conservatively. And then the next part here, we made an assumption about the number of claims that we could process just one day faster. And when you're looking at this in aggregate, you're actually collecting $121,000 a month faster by just having a minimal effect on the process. And that is a very attractive number when you talk to your business office manager, your CFO, because yearly, as you can see, it's about $1.5 million you're collecting faster. That can make a lot of difference in trying to stretch the amount of money. You're not necessarily saving the hospital that money. You're taking cash and putting it into a bank faster. This process is definitely has a hard dollar edge and something that's worth looking at. Again, that's one reason, and we'll talk about this in a little bit, looking at the business office area for some enhancements, because sometimes there's ways that are being done now that are just inefficient. You can have just such a tremendous impact. Get people excited about this. In this particular facility, they got so excited about what this process could do. They're spreading into other billing and claim rejection workflow within the business office, but also simultaneously spreading it to several HR workflows as well. And they sort of have a fire about them. And they're also, by the way, doing this at the same time they're implementing an EMR. And they too kind of found it beneficial to let's try to have a dramatic impact on the entire hospital all at the same time. Okay, why does this process work? It's obviously automatic policy-driven routing. Depending on how that form with those little drop lists were filled out, that would dictate how this form would route. So it didn't have any human involved, somebody routing it to the wrong person. Like when something was filled out, it was routed back in the most efficient way possible. Another part that's really pretty huge and really goes towards any electronic workflow is accountability. Thing is electronic, you know where it's at, how long somebody's had it, how long it's taken them to handle it, and if something stays in somebody's inbox too long, the system can also notify you, it can notify their supervisor, it can send them a friendly email. There's a lot of ways to start ringing the bell when something gets bogged down on any one step of a workflow. Methods were failing them. They were faxing some of these claim rejections, depending who they were sending it to. They were emailing, and there was a lot of phone calls involved. And they're spending a lot of time just following up on claim rejection notices that they sent out for clarification the day before. And it was doing up their time, plus it just wasn't working very well. And those are all the reasons why paper and paper processes really have to be looked at and scrutinized very heavily, in my opinion. When you're looking at Medicare payments that are $1,500 and you're receiving them, your cash flow is $150,000 a day. take that $150,000 a day, and let's just say you have a few percent increase. You can get bills out a little sooner. That is a $1.5 million increase in cash flow per month. And there's a lot of pay dirt here for you to start looking at tweaking hospitals' workflows. Look in the business office. There's just a lot of processes there. And believe me, these are well received. Most business office directors are in a hot seat these days. There's a lot of pressure on collections. And you can do to fix that process to get either coding done faster, claim collections done faster, really makes a difference. Certainly other revenue cycle workflows that are pretty popular. Audit management, I had showed you that that image before, the workflow. There's certainly, a lot of efficiencies that can be gained there because you're taking time away from people who are collecting money, who are getting bills out. You're taking those people away from those positive functions to defend audits, to try to keep the money you've already collected. And that's a very frustrating, time-consuming capture. There's, that's definitely an area to look at, as well as just charge master, keeping updates, keeping the whole process of keeping the charge master up to date and all the approvals associated with that. There's certainly other areas. The area I wanted to talk on before I get to questions and answers is just examining different areas for the biggest impact. Where are you going to hit, the impact in your hospital? Labor-intensive areas are a good place to look. Business, accounting, medical records. They're labor-intensive, and I don't mean to insinuate that they've got more people than they need. They don't have enough people for what they need. There is a lot of very busy people, a lot of paper shuffling, a lot of things that just get overlooked. A little impact can make a big difference just because of the sheer amount of people on a particular workflow at a given time. A lot to do with accounts payable. The whole process of how a hospital pays its bills and stays away from late fees is definitely worth looking at. Medical records, how requisitioned, even issues like, are we getting all our forms barcoded? Are we still signing forms on paper? I'm going to scan them in later, or we can start looking at other electronic signature for patient forms, so we can eliminating some of that backroom scanning that just chews up so much time. Others that are just seas of paperwork. Human resources, even with Lawson or Kronos, there's a lot of paperwork. PO requests, tuition reimbursements, personal action request forms, employee actions. There's a lot of different type of paperwork associated with human resources, efficiencies there, and all of that can be addressed. And employees happy. This has a lot of, you save a lot of headache and personal time in human resources. But particular workflows tend to make your employees happy. They like the process now. They now can see where their request is at. They're not with that little inter-office envelope being carried around by Frank to make its round before they find out whether or not they got their time off they requested. Again, accounting, a lot of work in accounting, compliance, just a lot of tracking and implementing changes to forms and other things like that can be looked at in the compliance area. Shortage of staff. This is really all areas of the hospital. It's really particularly hit hard with the shortage of staff. Every hospital has one area that's probably suffering a little bit more than others. This might be a really good area to start. Look what we're doing. Is this, are there things that we can do and automate here that will make life easier for maybe eliminate the need for extra staff. Likewise, talk about soft costs. If you implement some workflows in another area, maybe you free up some in the HR department. Maybe these employees can transfer over to the department where there's a shortage of staff. It changes their career. Likewise, it allows you to shift staff around without increasing your payroll dollar, and it's a huge benefit to the hospital. High volume areas that just have a really high volume of work. Materials management, coding, accounting, we've talked about them a lot, medical records, business office. Materials management, just so many involved with receiving, inventory, everything, and I know sometimes contract management will sometimes float. Every hospital is a little bit different. Sometimes that's owned by accounting, others it's owned by materials management, but contract management is one of those areas where contracts are sitting in a system and they get overlooked, and next thing you know, they auto-renew, or paying support on something that you no longer use. There are definite workflows and electronic storage mediums like that. It can make a big difference. And when you look at the sheer volume of contracts that hospitals have, it's not unlike the hospital have anywhere from 2,000 to 4,000 contracts. And those have different terms, different expiration dates, they kick you into a higher rate. And what you have to do is overlook the things. I think the vendors have mostly figured this out. They know hospitals are most likely to not be on top of those dates. So a lot of contracts, in my experience, will have a lot of triggers in there to where it'll bump you up to the next highest payment level or interest rate if you don't respond within a certain period of time, or auto-renew for a year or two if you haven't writing at least 3 months in advance. Things like that seem very punishing, because I think a lot of them have figured out how we just don't do a really good job with that. So with that, I only have a little bit of time left, but if there were any questions and answers, and I don't know if Aaron, you kind of want to or how you'd like to do it.
Sure. Yeah, we're going to open up for questions and answers at this point, the Q&A section. We did have a couple that came in during your presentation, Scott. One of those being, does this work with Meditech? And I think that came in around the time you were showing McKesson.
Absolutely. Yes, absolutely. The software is Formfast software, and it's been Formfast and a Meditech partner and working with Meditech since 1992. So there, definitely some advantages to working with Meditech and Formfast.
Great. And then came in, does Formfast help us figure out how to make our processes better? Actually,
we do. It's something relatively new, but we are offering varying levels of consulting services. How deep of a dive, it can range anywhere from no cost to some cost. But it is something that we can do. We have solution architects whose whole person life is going out to different hospitals and looking at these processes and trying to discover processes and cover them. So work with people in the hospital to show them how to do it themselves. A lot of times, hospital just sort of needs a little kickstart, and usually a fire gets lit, and they tend to take over. But it's definitely something that we can help with.
All right. For final questions to come in. I know we're running short on time here, but as we're waiting for a chance to get your questions for Scott, a reminder that we do have our previous webinars out in our resources library at formfast.com/webcast. So, take a moment to explore our website and part in check some of those other webinars we've done in the past. Looks like that might be it for the questions in this session. And with that, I'd like to thank Scott Fuller for taking the time out of his busy schedule to be with us. Thanks, Scott. It was a great presentation.
Pleasure. Everyone for their time for attending. I really appreciate it. Thank you.
And if you'd like to speak directly with Scott about some ways that you can make your organization a high-performance hospital, we'd be happy to arrange a time for you to speak with him. At the conclusion of this event, you'll be presented with a response page. Simply click on the button on the screen to schedule a consultation, and also make sure to register for the next webinar in the series. You'll be able to do that on the button on that page as well. Thank you all for attending today's event, and we'll see you at the next Formfast webinar in the fall.